Great. Well, I'd like to thank SAGES for the opportunity to present our experience with prophylactic inferior vena cava filters in high-risk bariatric surgery. Yeah, no disclosures. The prevalence of obesity is increasing in the United States and worldwide. There's estimated 64 million obese adults and 15 million morbidly obese adults in the United States alone. This has significant effects not only on the individual with respect to comorbid disease states, but also on the healthcare system as a whole. Now, bariatric surgery is an effective treatment for morbid obesity, and the number of procedures continue to increase on an annual basis in order to meet the increasing prevalence. These procedures are not without risk, and one of those risks is venous thromboembolism. Although the overall incidence is only 1 to 3%, it remains a significant cause of morbidity and mortality in these patients. They all receive VTE prophylaxis, but the optimal drug, the optimal dose with respect to their weight and the duration of prophylaxis extended beyond hospitalization or stopped at the end of hospitalization remains to be worked out. There's a subset of patients, the high-risk patients, that are defined by those with a previous history of a VTE, either a DVT or a pulmonary embolism, those with a BMI greater than 55, a known hypercoagulable disorder, or those with severe immobility or marginal pulmonary reserve, where they wouldn't be able to tolerate another insult. Many have turned to retrievable inferior vena cava filters for these patients in order to protect them from PE, and the literature has borne out that the filters actually do protect from PE. However, they are associated now with an increased risk of DVT with longer dwell times. The purpose of our study was to evaluate the retrievable inferior vena cava filters in conjunction with standard VTE chemoprophylaxis in the high-risk bariatric surgery patients. We looked at all of our high-risk procedures from February 2007 to July 2009. We had 44 total patients, all of which met the NIH criteria. They were all evaluated preoperatively with lower extremity ultrasound to show that they don't have a DVT, and they underwent our VTE prophylaxis. The prophylaxis for our patients includes chemoprophylaxis with heparin, 5,000 units sub-Q 3 times daily, started preoperatively, pneumatic compression devices placed preoperatively and throughout their hospitalization, and early ambulation on postoperative day 0. The filters were placed on the day of surgery just prior to the bariatric procedure. We used either the Gunther Tulip or the Bard G2 filter systems. They were fluoroscopically guided. For those patients that exceeded the limitations of the fluoroscopy table, intravenous ultrasound was performed for placement. The proposed and planned procedure was the laparoscopic gastric bypass. Postoperatively, these patients were evaluated with lower extremity ultrasounds at any time during their postoperative course based upon clinical suspicion or at the time of filter retrieval on the table just prior to their retrieval. They also underwent an iliac and inferior vena cavagram to assess for thrombus in the filter and in the vena cava at the time of retrieval, and they were retrieved with a cone retrieval device as depicted here. Overall, we had 44 total patients with a mean age of 48 years. The mean BMI was 58, and the average operative time was 111 minutes. The length of stay for the whole group on average was 3 days. 41 of our 44 patients underwent the laparoscopic Roux-en-Y gastric bypass. There were 3 conversions, 2 of which were revisional procedures, and 1 was due to dense adhesions from previous surgery. The indications for filter placement in our group, the most common was a BMI greater than 55. 30% had a history of previous VTE, although no hypercoagulable state, and 1 with severe immobility, and this patient was wheelchair bound. The most common filter access location was the right common femoral vein, followed by the right IJ and the left common femoral vein. 28 of the 44 patients had their filters removed. That's 65% retrieval rate. Our dwell time, which is the time from placement to removal, was quite long at 200 days, and that's a mean number. The BMI difference at the time of placement and at the time of last follow-up was on average 12.2. Comparing the patients that had their filters removed and those that continued to have their filters in place, we noticed a significantly longer operative time in those patients with their filters in place and a significantly longer length of stay. There were two complications of filter placement. One was migration, and one was extended groin pain for 5 days. There were no complications of filter removal of those patients that had their filters removed. Postoperatively, we found 2 DVTs, one on the ipsilateral side of filter placement and one on the contralateral side for an overall 4.5% rate of DVT. There were no PEs, and there was one death, which was cardiac in nature with no PE on autopsy. So in conclusion, retrievable filters are safe in the high-risk bariatric surgery population. With our long dwell times with a mean of 200, they can be removed safely with an acceptably low incidence of DVT, 4.5%. However, despite this, every effort should be made to retrieve these filters as soon as the patient's risk is reduced because the long-term effects are unknown. And filters in general are now being associated with a higher incidence of VTE with the longer dwell time. And this should also not diminish the importance of chemoprophylaxis as the primary modality for VTE prophylaxis in this patient group. Thank you.
Thank you very much.